Good afternoon, all of you. So I'm going to present this trial which was published in Lancet Oncology and also presented in ESMO Immuno-Oncology Conference. So I'm the TIGIT, that is T-cell immunoreceptor with Ig and ITIM domains, is a novel inhibitory immune checkpoint presented on activated T cells and NK cells in multiple cancers. TIGIT expression, it correlates with PD-1, especially in tumor infiltrating cells. Tiragolumab, which is an anti-TIGIT monoclonal antibody with an intact Fc region, is thought to block the binding of the TIGIT to its receptor PVR. The hypothesis is that anti-TIGIT antibodies such as tiragolumab, this could restore the anti-tumor response and may amplify the activity of anti-PD-L1, PD-L1 antibodies. This Statistic is the first randomized phase 2 trial of anti-TIGIT antibody, and at the primary analysis, tiragolumab plus atezolizumab showed a clinically meaningful improvement in overall response rate and PFS in the intention to treat population compared with atezolizumab monotherapy. Tiragolumab was granted the breakthrough therapy designate by the US FDA in combination with atezolizumab in the first-line treatment of patients with metastatic non-small cell lung cancer. And here the presentation is on the updated 30 months survival. So Citiscape is the first-line stage 4 non-small cell lung cancer patients who were EGFR ALK wild type, tumor PDL1 assessment done by 22C3IC, and the level was more than equal to 1%. Stratification factors included PDL1 tumor proportion score, histology, and tobacco use. Randomization 1:1 to tiragolumab plus atezolizumab or to placebo plus atezolizumab, no crossover until the progression of disease or loss of clinical benefit. And the co-primary endpoints were overall response rate and progression-free survival. Key secondary endpoints were safety, duration of response, and overall survival. And the exploratory endpoints were efficacy analysis by PDL1 status. Now, as I previously mentioned, that primary analysis was done in 2019, and that showed a benefit, and the median follow-up was only 6 months. And now this updated analysis is after a median follow-up of 30.4 months. Baseline characteristics in the intention to treat population in both arms were well balanced. So the investigator assessed PFS in the intention to treat population. If we see the tiragolumab plus atezolizumab arm, the median PFS was 5.6 months in comparison to 3.9 months with atezolizumab monotherapy. The hazard ratio being 0.62. The overall response rate was 38.8% versus 20.6%, and the median duration of response was 17.6 months versus 10.7 months. Now, if we see this PFS in the PDL1 subgroups, there is a marked improvement in the PDL1 TPS more than equal to 50%, where the median PFS was 16.6 months in comparison to 4.1 months, and the hazard ratio of benefit was 0.29, and the median duration of response was 15.7 months versus 8.2 months. If we see the PDL1 TPS score between 1 to 49%, here there was not much benefit because the median PFS was 4 months versus 3.6 months, and the hazard ratio actually was 1.07, and the overall response rate was actually 15.8 versus 17.9 months. Coming to the overall survival and intention to treat population, the experimental tiragolumab plus atezolizumab arm had a median OS of 23.2 months versus 14.5 months with atezolizumab monotherapy, and the hazard ratio was 0.69. If we see these PDL1 subgroups of overall survival, here also we see that in PDL1 TPS more than equal to 50%, the median overall survival with the experimental arm has not reached versus 12.8 months, and in PDL1 TPS of 1 to 49%, we see that tiragolumab plus atezolizumab had a median OS of 13.3 months versus 14.5 months. Coming to safety overview, there was not much added toxicity with the addition of tiragolumab to atezolizumab. And if we see the immune-mediated side effects, they were slightly high in the tiragolumab plus atezolizumab arm. And there were adverse events leading to dose modifications. It was 33% versus 24%. And the adverse events leading to treatment withdrawal, it was 10 versus 9. So it was almost the same. If we see the incidence of adverse events overview, we see the grades of 1, 2, 3, 4. The only concerning grade 4 adverse event was increase in lipase level with the use of tiragolumab plus atezolizumab, and this was significant in comparison to the atezolizumab monotherapy. Patient-reported outcomes assessed by EORTC questionnaire of C30, it also showed that physical functioning and role functioning was better with the combination. So to conclude, at this updated analysis, Tiragolumab plus atezolizumab provided a clinically meaningful improvement in PFS, overall response rate and OS in the intention to treat population compared with placebo plus atezolizumab. With 30 months of follow-up, the median OS was not reached in the PDL1 more than 50% subgroup, and it was consistent with the primary analysis. Tiragolumab plus atezolizumab was well tolerated. Following longer follow-up, no new safety signals were observed with the combination. Patients generally maintained their baseline quality of life. Lung cancer-related symptom burden remained minimal to moderate over time with patients with the combination. And durable responses and encouraging OS continue to support evaluating Tiragolumab plus atezolizumab as a chemotherapy-free regimen in metastatic PDL1 high non-small cell lung cancer, and the observed activity and safety is to be confirmed in an ongoing phase study, Skyscraper-1 trial. Thank you.